guest speaker, Maggie Farrell, will be presenting on the topic Understanding Kidney Transplant Evaluation. Maggie is the transplant manager at the Cedars-Sinai Comprehensive Transplant Center, managing the kidney and pancreas programs. With over 20 years of experience, Maggie is an experienced and passionate transplant professional who advocates for and promotes advancements within the field of transplantation. While balancing leadership and operational responsibilities, Maggie continues to work on various efforts to improve efficiencies and establish best practices for the care and management of pre- and post-transplant patients. Additionally, Maggie is dedicated to improving and increasing patient education and access to transplant through ongoing partnerships and participation, both within the organization and in the community. Please join me in welcoming Maggie Farrell.
Good afternoon, or I think it's almost afternoon. I am very happy and was very pleased to have Lori's invitation to come speak and be with you guys today. I appreciate Lori and the whole RSN team who's put this on and collaborated with many different entities. It looks like we have patients here, we have dialysis centers here, and we have Amgen people here. I think we've got a good cross-section. So what I wanted to do just first is to see how many patients are actually in the audience, if you could raise your hand. Yeah, a good nice amount. Awesome. Okay, so we'll get started. I'm Maggie. I'm the manager of the transplant program at Cedars-Sinai, at least the kidney and pancreas portion of the Comprehensive Transplant Center at Cedars-Sinai. I would like to go over all entities of transplant evaluation and just some really important pieces that Lori felt was very impactful, and so I hope you enjoy. So next slide. This is our overview for today, so we'll talk about major causes of ESRD, the status of the waitlist, which we touched on earlier today already, advantages of getting a transplant. How do patients start the process, which is the biggest key here, and phases of transplantation, what that evaluation looks like, types of transplants, compatibility, transplant compatibility, antibody levels in treatment, and resources. Next slide. So the transplant list, which we'll look at here in a minute, is growing, as Lori mentioned earlier today, growing by the moment. And there's several reasons why people lose kidney function, certainly far more than what I've listed here. But I think the point is that these are the major causes, many others that are out there. But what we're seeing is the two on the top are highlighted because the diabetes and hypertension, which is growing across our country and worldwide actually, are actually causing the majority of cases for people that are losing kidney function and requiring dialysis support. Next slide. So here's kind of a snapshot, and this is as of May, of what the transplant wait list looks like per organ. So you can see we're at 105,000 people across the country that need an organ, and the majority of those are needing a kidney. And I know this is daunting to look at, and it's not, I'm not advertising this as a downer. It's really, it's education. It's really knowing what you have to do if you're in that mix and what that means for you. So I think that's why just putting a focus on the pieces out there that people can do to not make themselves another statistic and really have that education to move forward. Next slide. So everybody, patients-wise and in the industry, know what stages of renal function or renal failure look like. So really the point of this slide is two things. I wanted to talk about when we get referrals for transplant. And I'm still not happy with the answer I'll give. We actually get referrals for transplant patients, for patients that are almost always in stage 5. which means people have been on dialysis for maybe a short time, but maybe a very long time as well. And we're trying to change that culture because I've been in transplant for 20 plus years, and we're trying very hard. But I tell you, it's tough. We're still getting late referrals, is what we call it. And the whole point is that if we can get patients referred earlier, patients will get education earlier, they'll get taken care of earlier, they may bypass having dialysis altogether if they're referred early enough. So that is what we're doing. And we do have an outreach coordinator at Cedars, and most of the big transplant centers do. Our outreach coordinator goes out into the community to dialysis centers and to referring providers' offices, and believe me, she talks about this. And we're really promoting sending early referral. So that was my first piece. And my other piece was just knowing that, and this is an educational piece, is that patients that get listed on the national wait list have to have that GFR in the 20, has to be 20 or less in order to gain time on that list. So again, you can see in the stage 4 range, if anybody that comes at that level is already, if they're 20 or below, will be able to gain time on the wait list. Next slide. So transplant is certainly not for everybody, and I appreciate that. But I think what I'd really like to discuss or outline is that there's really major advantages to transplant. There's certainly hard work and a lot of responsibility. And can I point you out, Jorge? So my current patient is here sitting at the table. I got to see him today, and he's firsthand can tell you that it's no cakewalk. It's no easy road. It's a lot of work and a responsibility. But I think what it is it frees you up. And number one, you rid of dialysis responsibilities. You have an energy level that now is brand new to you. You have a diet and you can taste food again. You do not have to worry about fluid restrictions. You feel better physically. You now can travel without the worry of dialysis. And you have an improved presence with your family, with your friends. You feel better, you're more present. And lastly, just an overall better quality of life. Next slide. So I think, Lori said, this is a very, can be a very complicated process, and people don't know how to start. People don't know about transplant, or they don't know how to proceed, even if they do know about transplant. And let me just say for the dialysis patients in the room, that your social worker and your referring provider, your nephrologist, is the two people that can and should be educating you to this option if this is something that's right for you, it works for you. And if it is, and you're still, during the headlines because it's a big giant deal, which I think we all in this room and in the industry understand. So I just want to go through, how does somebody start the process? So it's about conversations. Again, it's about talking to your family, talking to people that are close to you, and discussing the option. Is that right for me? Is it not right for me? What does that mean for me? Your social worker, again, at your dialysis unit, your nephrologist, your primary care doctor. Those conversations should happen so that you can start thinking about whether it's something you'd like to proceed with. Also, resources. So, right, knowledge is power. If we don't have that, we're in fear. So I've listed things here, and this is just a few. I put, of course, our renal support network, which is full of resources and information. UNOS, which is the governing body of transplant across the United States, as well as the oversight of OPTN, and the National Kidney Foundation. All of those resources have online education for patients. It's certainly, there's a huge element on there about providers and transplant centers that's focusing on their needs, but there's a massive piece in there about patient education. So I always try to have patients go here as well to just gain additional information in addition to what we're telling them. Next is, choose a transplant center. What transplant center is close to your house? Which one have you heard about? Which one has had you've had a friend or a family member have a good experience there? And does it work for your needs? And now what do I mean by that? If you have a living donor and you want to be part of the, kidney paired exchange program, which we'll talk about in a little bit, do they participate in the kidney paired exchange program? Do they maximize organ utility by way of utilization of hepatitis C kidneys, hepatitis B kidneys, a variety of different organs that are being utilized now to get more patients transplanted. It's really a key piece of what you should be asking when you're deciding what center to go to. And then lastly is just understanding the transplant process. What qualifies a patient to be transplanted? Because not everybody can be transplanted. There are some rule outs for sure. But listen, if somebody wants a transplant, we want to make sure that we can get you to that point, but we have to do it safely. And we got to make sure that you qualify medically, and psychologically, socially, all of that. And of course, your insurance is a key piece of where you go. Also, how long does it take? How long does the process take? Well, I'm asked that all the time, and that's an open question because sometimes people get through the process very quickly because maybe their workup was a little more straightforward. On the other hand, on the other side of that is somebody that's very medically very complicated. And that will take a whole lot longer than somebody who's straightforward. And so there is no clean answer for that. Everybody's individual. How long will you have to wait for an organ? So that's a big question too that we hear a lot of. It's a long wait on the national wait list. It's a long wait to wait for a deceased donor transplant if you don't have a lot of time, right? And your time starts from either the time that you start dialysis or from the time that you're listed on the transplant list, whichever one fits you. So I always want to make sure that patients out there really realize, I don't want to transplant, I don't want to have to wait that long. But remember, if you've been on dialysis, your clock will start from the time that you started dialysis. So that buys a lot of time for people. But just of note, in Los Angeles, the wait times, again, this is not to be negative, this is the reality of where we're at, is that the wait times are exceeding 6 to 9 years depending on blood group. So, and that's daunting to think about that. And then there are other things that could shorten your time, and we'll talk about that in a little bit. But I always want to make sure that people understand that because I think some of the other things that you can do to help yourself through the process can eliminate some of that. And then what happens once you're transplanted? Lastly, and that's really what's the responsibility of a post-patient, and it's a lot. Right? It's particularly in the beginning stages. Post-transplant is a lot of responsibility by way of clinic appointments, by way of lab draws, by way of just the responsibility, taking your medication, taking it appropriately, making sure that you have everything that you need to make sure that you're keeping yourself healthy and that you're keeping that organ going. Next slide. So phases. I'd like to highlight, we won't go through all of these today, but I want to highlight the referral phase. So patients can be referred to any transplant center by way of 3 methods. Your dialysis center, social worker can send a referral over to us. Your nephrologist can send a referral over to us. And lastly, you can self-refer yourself. So if you want to call us and say, I want to be looked at and evaluated for transplant, you very much can do that. You do not have to have a referral from a provider. Next is the evaluation phase, and we'll talk about that obviously in more detail. Once you're done with your evaluation, complete evaluation, you get presented to our selection committee, and that selection committee determines whether a patient is suitable, healthy, safe to proceed with transplant. If they deem you a suitable candidate, then the patient gets listed on the national wait list. You're now in what we call the wait list phase, and that's either you're waiting while your living donor gets worked up, you're waiting while your antibodies get treated, or you're waiting for that deceased donor to come. Treatment phase, and that's the antibody phase that I'll talk about in a little bit, and then transplant and post-transplant. Next slide. So patients that come for evaluation, it's a big, giant appointment, to be perfectly honest. And for the patients out there that has gone through it, you know what I mean, or the patients that are thinking about it, please remember this is, it doesn't matter what transplant center you go to, the evaluation appointment is a lengthy one. Sometimes it's a half to a whole day, depending on how much we're getting done in that visit. You 100% will be evaluated by all of these providers that are on the slide right now. And that's really the bulk of what takes so long. So every single person you're seeing by a transplant nephrologist, a transplant surgeon, the coordinator, a finance coordinator, social work, a living donor coordinator, and a dietitian. So all those folks evaluate you to your candidacy for transplant. In addition, a patient could go have their labs done that day. They could go have imaging that day. They could go have a stress test that day. There's a number of things that we can get out of the way on the day of the evaluation, which will start. But my point is, it kind of starts the clock of getting your process started. What I really want to highlight also is that patients often leave the clinic on the day of their evaluation appointment, and they think they are leaving, and they're listed. They're on the list. And there's a giant misnomer. Patients are 1 million times not listed when they leave the clinic. They have to go through that whole process and be deemed suitable before they're listed. So we really try to hone in on that and make sure that patients aren't, it's a confusing process. So we want to make sure that they know that they're walking out with, it's just the beginning after that appointment. Next slide. So my next huge piece of advice in this process is really knowing your transplant team. And I happen to be at Cedars-Sinai, but there's neighboring centers on either side of us, USC, UCLA, fantastic programs, all filled with amazing, passionate, really dedicated professionals that are here to get patients where they need to be. So my big take home from this is to understand who those people are. So you have, like I said, all of the folks that would evaluate a patient at the clinic, and then you have the two that are highlighted at the bottom. And I'm not trying to be biased, but the coordinators and the administrative assistants are kind of your go-to, right? Those guys are going to be. Number one, you want to know their name. You want to know what their role is for you, because they're the ones that are going to move you through the process and help. You're going to have a partnership with those two people. Hugely, hugely important. I oftentimes hear patients say, I don't know who my coordinator is. I don't know how to get them. So my advice is always know who they are, those two people, and know how to get them. Next slide. So while you're at that transplant appointment, they're going to describe the options, and you're going to have to make a lot of decisions the day of transplant as to whether you're comfortable with entertaining different types of organs. And this is what I talked about earlier. So on the deceased donor side, there's the standard criteria kidney, standard criteria organ that everybody is eligible for. And then there's what we call a high KDPI donor. And that is donors that are older age and maybe more complicated medical history. And really those are for patients that are recipients that are older themselves and don't have the extensive amount of time to wait. So a lot of times patients will opt for this option. This doesn't mean it's marginal. It means that it's not a pristine standard criteria. It means that kidney, that KDPI kidney, is going to be biopsied at the time of the procurement to determine whether it's suitable and functional for you. And then, of course, there's I put in about direct donation because we not often, but we frequently have patients that are waiting on our list, and they have had an unfortunate event with a family member or a friend of a friend who's had a horrible accident and are now on life support, and that family has decided to donate a kidney to a patient on our list, and that does happen. So know that that's an option too, and it's as unfortunate as it is, it's actually possibly giving that recipient a whole lot sooner transplant. A whole lot sooner. Also under the deceased donor is what I mentioned earlier, is the utility of organs, really trying to maximize the utility of deceased donors by way of utilizing hepatitis C donors, hepatitis B donors, which have come a long way. There's now treatment pieces in place for those, so they're very viable. Is what I'd like to say is they're very viable options for patients, and are helping us the utility of organs. Also, what we call A2 to B. So A2 to B transplants are recipients who are B, who could take what we call an A2 organ, but you actually have to consent for that as well, and your blood has to be tested for certain elements as well to be eligible for that. So when patients are getting evaluated at the transplant center, these are the things they have to learn about. These are the things they have to understand and make decisions about and consent to. And then living donor. So living donation is still. I love Anne's story, and what a success story that you and George had, and the amount of public speaking and public engagement that they've had has really helped. And we need more people like Anne and George that are out in the public eye that can get that story out, because let me tell you, it's tough. Patients. There's many patients that don't want to ask their family. They don't want to ask a friend. It's a real issue still, and we're trying so hard. Again, back to my outreach coordinator that goes out into the community. She's persistently talking about living donation, and then how it will benefit not only the recipient, but how it's very doable for the donor. And so again, this does not have to be your family member. Certainly family members are great because you've got DNA matching there, so it makes it a whole lot more possible, but it does not need to be that. It could be a friend. It could be a friend of a friend. It could be somebody out in your community that heard your story. It could be an altruistic donor, completely somebody who you have never met and they don't know you. In fact, it's one of those things that doesn't happen every week, but it happens more and more now. At Cedars, we'll have a donor call us and say, I want to give my kidney to anybody who you tell me who you want to give it to, and we basically work them up to make sure they're a safe donor, and then it goes to that top person waiting on the deceased donor list at our center. So there's huge opportunities here, and then we haven't even talked about the exchange programs. So the kidney exchange programs are the swaps. Everybody knows about what the kidney swaps are now, kidney chains. They're happening across the country more and more. The biggest registry that we belong to is the National Kidney Registry. And they're very well known now. They're across the country, and they're doing amazing work. Every year they transplant or assist in transplanting more people. So we are very involved with them, and we're involved with a couple other registries trying to expand the possibilities for our patients. So point is that if you are choosing a center, you want to make sure that if that's what you want to be involved in, is that they actually have experience and are actively working with the NKR, National Kidney Registry, or one database for matching. Next slide. We also do pancreas transplants at Cedars and pancreas, and the reason why I bring it up is that sometimes patients that are waiting for a kidney are also waiting for a pancreas. So they're type 1 diabetics, so they're requiring insulin and they're requiring dialysis. Patients that are in that situation and that are deemed suitable to proceed with a dual organ transplant can qualify for that. And patients in this setting have two options. They either get a donor and get both organs from that donor and get transplanted with a simultaneous pancreas and kidney. Or they get their living donor kidney transplant because that's what the patient prefers, and then they wait 6 months or so until they're cleared, and then we put them back on the list for a pancreas and they get their pancreas. Pancreas transplants happen, a lot less than kidneys. They're really not abundant, but they do happen, and there's certainly a subset of patients that can benefit from that. Also, we have dual organs that are possible: liver kidney, heart kidney, lung kidney, for patients that require that. Next slide. So the guidelines or the workup for an evaluation patient can be, like I said earlier, pretty extensive. And what I've listed here is just very general. This is the preliminary workup for a recipient coming in to be evaluated. So very routine stuff like an EKG and chest X-ray. Very standard like blood testing. In addition to blood testing, we need tissue typing and we need blood typing. So those two things are taken on the day of evaluation, and those play a huge key role into compatibility, which I'll talk about in a little bit. We want to do heart testing like stress tests, cardiac stress testing on patients that are 50 or over, or diabetics that are 40 and over, and colonoscopies for patients over 50. Any patient that's already being seen by a specialist, a pulmonologist, a hepatologist, a psychiatrist, anybody who's being treated presently for one thing or another has to be, that specialist has to clear that patient to tell us that they're okay with us proceeding. So clearance letters are required from all specialists. Also, you could have an abdominal CT to check vasculature on patients. And then lastly, I'm saying any additional testing because it is routine that this is, like I said, a very preliminary list. Many times, I should say most times, it will snowball into something else. For example, a cardiac stress test is done on a patient who's never had one. The stress test shows X. Now we're sending them to cardiology. Now we're waiting for additional testing that is required by the cardiologist, et cetera. So you can imagine the snowball of testing that can occur with medically complicated people. So I always like to make sure I say that. Straightforward people could go through the process in, a few months if they were very motivated. But patients that require additional testing and are more complicated could take up to a year, depending on what the circumstances were. Next slide. Additional requirements that patients will need to do is, this is really the functional assessment now is very, very key because we're transplanting more patients that are older. And older patients sometimes have been transplanted a few times and they've got other more medically complicated issues. We need to make sure that their functional assessment is solid to put them through a transplant meeting. If somebody is difficulty with walking, difficulty with stamina, a number of other things like that, and you transplant somebody who's got significant concerns in that regard, it's tough. It's been not only tough, but it's been sometimes poor outcomes. So because of those poor outcomes, now there's a big scrutiny of the functional capacity. And how do we test that? There's a number of tests that can be done in the clinic that test functional capacity, and the one we happen to do is called a 6-minute walk test. That means that we watch how somebody is able to walk over a 6-minute period of time in the clinic and monitor their vital signs and determine how far they can go in that 6 minute, basically. Also, requirements are BMI requirements, and I did not put a number here because every transplant center has a different cutoff for BMI. At Cedars, our cutoff is 40, a BMI of 40 or lower. Housing. So in order to get a transplant, patients have to have stable housing. They have to have somewhere where it's safe, where it's not going to be a potential complication post-transplant where they're living. And the social workers play such an instrumental role in making sure patients have adequate housing and are set for that. Also, the caregiver plan. So patients, and I don't think we're unique to that, I think it's every transplant center, require a caregiver. So you have to have a caregiver primary and a secondary caregiver that the social workers really have to confirm and talk to. And that's hugely important, and it's not necessarily while you're waiting on the list, but it's when you're transplanted, the point is you've got to have that person or persons to help you get through that. And mostly, it's providing support post-transplant, of course, but it's driving them to clinic. It's making sure their medications are taken appropriately. It's making sure that they're supporting them when they're not feeling good. There's a lot of need for that. So you'll know that is a requirement for the evaluation. Next slide. So once that whole workup's done, so the patient's had everything done, every test that has been asked for has been done, reviewed, and approved. They're presented to the selection committee, and the multidisciplinary team now evaluates that case to make sure that it's safe to proceed. If they get the approval to proceed, they're now listed on the national wait list. And when patients, and here another take home here is what I said earlier about making sure that that patients think, they don't think they're listed when they walk out of the clinic the day of eval, because they're not listed until they actually get that coordinator call saying that they've been listed and that they've received the letter in the mail or through their medical record. Very key piece to know they're listed. And then the waitlist phase begins, and you either now are waiting for your deceased donor or you're now waiting for your living donor to be worked up. Next slide. So I want to talk about compatibility because I think it's another area where people don't have a huge amount of knowledge. Patients don't have a huge amount of knowledge going into it. So compatibility is twofold. It's not only blood type. So blood type has to be there, but we also need tissue typing. And so those two things that are taken at the evaluation appointment are tested to make sure we know your blood type and we now know your tissue typing. And we can mix that with any potential donor that you bring forward. So if it's a living donor or we're now got an offer for you for a deceased donor, we do what we call a cross match. And that cross match is where we take the recipient blood and the donor blood and make sure that it's an acceptable cross match. It's compatible. That's the key. And basically you want it to be compatible because we're trying to prevent rejection. We're trying to prevent all the complications that can occur if we don't have a suitable compatibility. This is routinely done before any transplant. A cross match. And dialysis patients are very familiar with getting their sera blood samples drawn at dialysis, and they're sent to the transplant center to make sure that a current sample is available for that cross match. So different centers have different requirements in terms of how long that sera is good. For us, it depends on the patient, but for the most part, we have that criteria out, and we notify each dialysis unit to say, this is the patient we need drawn this month. That kit goes to the dialysis unit, the blood gets drawn, it gets sent back to the transplant center. And that sera is a key, because I can't tell you how often it happens, and unfortunately it does, where we have a deceased donor offer for a patient who's on our wait list and we don't have a current sample. And without a current sample, we can't run a cross match. Without a cross match, we can't proceed with a transplant. So it's critically important for our patients to understand that, for dialysis units to understand that. So the next thing I want to talk about, which is in the same theme of compatibility, is antibodies. So patients often say, I was told I have high antibody levels, but I don't know what that means. So antibody levels are proteins that circulate in all of our bloodstreams, and they play a key role in your immune system. They're kind of the fighter cells that help protect us. Hugely, hugely important. Next slide. So some patients will come forward and say, I have high antibodies. So how do you get high antibodies? Antibodies are developed by 3 different mechanisms. You either get them through a blood transfusion, either through a previous transplant, or a pregnancy. Those 3 mechanisms, you can develop antibodies. And some people have mild, low antibodies, and some people have very high antibodies. The point of the story about antibodies is if you have high antibodies, you will have a much more difficult time having an acceptable cross-match. So we have oftentimes patients coming to us saying, I have high antibodies, I've been sitting on the wait list waiting for a compatible transplant, and it's been X amount of years. So I say to those patients, you ought to make sure to understand what that means. How high are your antibodies? And have you received any treatment for your antibodies? Are you in a center that provides any kind of therapies for those antibodies? All hugely key important pieces. Because, of course, without treatment, without any knowledge about it, patients will make their already long wait time much longer. But I will say that Cedars, and just to be perfectly clear, Cedars has a full program for antibody treatments. We call it a transplant immunotherapy program, and it is for these patients. Science is evolving. It seems like every year we have new therapies that are coming out to help these patients. So they do have to go through a series of treatments pre-transplant in order to get those antibody levels down to a more acceptable level. And those are IV drug treatments, plasmapheresis, a number of clinical trials that are happening that are, kind of advancing the science behind this field. So point being is, if you're a patient, know your antibodies. If you have high antibodies, make sure your center has addressed it. If they are not able to address it, you want to get yourself to a center that can. If you're a dialysis unit, please, those are all great questions too, because if you have patients that you're referring that have already been transplanted before, chances are they have antibodies. So make sure that wherever you're referring them has some sort of capability of treating that. Next slide, please. So I said I referenced our neighboring centers, but we also have antibody treatments across the country. And the biggest centers, basically, just for everybody's knowledge, is Mayo in Minnesota, Johns Hopkins on the East Coast, and Cedars-Sinai on the West Coast. So they're the 3 biggest centers across the country that are working and have the biggest advancements in this field of antibodies. Yeah, and I talked about what the treatments are. And these are very standard treatments. What we use, IVIG, we use drugs called rituximab, and we use plasmapheresis. Plus, there are a number of trials. So most transplant centers are involved in research studies, some more than others. But there's a number of research and clinical trials going on to further advance the difficulties of antibodies. And this can be whether you're pursuing a living donor transplant or you're waiting for a deceased donor transplant. Either way, you have to have your antibodies lowered. Next slide. So what do you do now? Kind of what I touched about is knowledge, making sure you're at the right center that will meet the patient's needs, the individual patient's needs. You know who your coordinator is, you know who your administrative assistant is, because those guys should be on speed dial for the patients. That should be and I was sitting next to Grace at this table over here, and Grace named off not only her coordinator, without me prompting it, she named off her coordinator and her administrative assistant's name, and she knows how to contact them. So their direct lines, their emails, and their electronic medical record contact. Those are 3 huge pieces that every patient should have while they're waiting. Stay in close communication, as I said, and always ask questions. Any question, that's why your coordinator is there, that's why the team is there. So we always want patients to call and not be in the dark, and not know where they're at, not know whether they're listed or not. Call so we can inform. Next slide. The other thing is, while patients are on the wait list, depending on what center patients go to, will depend on when they bring those patients in. So I'm going to use my center, Cedars. If somebody's come to us and has gotten successfully listed, but they don't have a living donor and they have a long time to wait, we're not going to bring them into an appointment every year, because we don't want to waste people's time. We don't want to waste the patient's time. As they get closer up the list, and they're now either we've got a living donor that we're entertaining, or they're up the list and they're going to start receiving offers, we bring patients in then and make sure that they are still suitable. So they get re-looked at by all the consultants that they saw on the evaluation appointment, which is hugely important. Face-to-face opportunities to answer questions. I always say to patients, bring all your questions written down. We recheck antibody levels, because sometimes, again, if you didn't have high antibodies at your evaluation appointment, maybe there's been a couple years past, maybe there's been four years past, you've had a blood transfusion, you had a big infection, now all of a sudden you have antibodies. So we check for that in your waitlist appointment as well. We re-review all the different organ possibilities, that you are still comfortable accepting different types of organs. And then we update all the needed tests, studies, labs, all of the et cetera that are needed to make sure that you still remain a suitable candidate. And then the blood samples again, the huge importance on the blood samples. Next slide, please. So also important, if we're not seeing you for 2 and 3 and 4 or however many years, we want patients to call us. Did you have a change in address? Did you have a change in your phone number and your insurance? Did your caregiver plan change? Have you been hospitalized? Do you have a new medical diagnosis? All those things we are hungry to know, because the key is not to hold you up once that organ is available. The key is for us to make sure that we know it, we've looked into it, we reviewed it, and you're still suitable and safe to proceed with transplant. So anything that's on this list, or you have a new donor, you have a potential donor, maybe I have a donor, please call us and tell us that. Next slide. Okay, lastly, I want to say is not only keeping in touch with your transplant center and getting your questions answered as they come about, but also the resources that I talked about earlier. So UNOS and OPTN are the governing bodies that manage transplant across the board in our country. There are resources, there's patient-specific resources that are there. Very important to keep that as policies change, as stuff changes.